Hello, and thank you for joining today's webinar. We will be getting started soon. Please share where you're joining us from today in the chat. Hello and welcome everyone. We will be getting started in just a minute, but as you can see from the chat, we're just putting in where you're joining today from. All right, well, welcome everyone. It's great to see all of you from across the world joining for us this important topic. So thank you for being here. This webinar is actually aligned with the type of content you'll find at Sigma's Creating Healthy Work Environments Conference, which will be March 20th through 22nd in 2026 in Washington, D.C. Abstracts deadline has been extended to October 17th, so there still is time. If you have any research or content or anything related to this important topic, feel free to submit. We will place a link for the call for abstracts in the chat now, and then also at the end of the webinar as well. Today's webinar is eligible for one contact hour. Sigma Theta Tau International Honor Society of Nursing is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Centers Commission on Accreditation. No one with the ability to control content has any relevant financial relationship. To receive contact hours for this NCPD session, participants are required to attend the webinar and log into our learning management system to complete an evaluation form. Information on how to access this will be emailed to all attendees 1 week after the webinar. This webinar is being recorded and will be available via the Sigma repository within a few business days of recording. Following the presentation, if we have time, we will have a question and answer session. You'll see on your Zoom webinar control panel that you can send a message through the Q&A feature. This is where you can type in any question you'd like to pose to the presenters. Be sure to hit send so that the message makes it to us. Please use the Q&A for questions and the chat feature to interact with other participants. We would like to thank our speaker for sharing their expertise with us today. Of note, thoughts and views expressed are that of the presenter and do not necessarily reflect that of Sigma. Our presenter today is Kelsey Springer. Kelsey Springer has nearly 10 years as an RN and 16 years of experience in healthcare altogether. Along with her personal experience with workplace violence, she has been published in the journal Critical Care Clinics. Kelsey also blogs about workplace violence and collaborated with the AACN for the 2025 NTI conference. She utilizes evidence-based practice along with her personal lived experience to advocate and educate on the topic of workplace violence in healthcare. Welcome, Kelsey. I'm going to turn it over to you.
Wonderful. Thank you so much, Megan. And thank you everyone for joining me this morning to talk about a pretty difficult topic, but a very important one. Before I get started, I do just want to put up a quick trigger warning that I will be talking about violence and assault throughout this presentation. I will not be going into any grave details, but please do not hesitate to mute this or step away if you need to at any point. So, as Megan said, I just wanted to share a little bit about me. I have been a nurse for almost 10 years as an RN, with most of my background in critical care. But I've been in healthcare for almost 16 or over 16 years, actually, and worked in a wide range of areas. And it's really important. Those different areas to what I'm going to be sharing today, because workplace violence has, I've experienced it in almost every single area that I've worked. Um, and I've taken that experience and that passion for really wanting to change what we all experience, and really learned a lot more about it, exploring the evidence, and really getting out there and advocating for safer workplaces. So, the objectives of today is I want everyone to be able to describe the importance of workplace violence recognition and prevention, and then be able to kind of take away some resources that can help you improve safety in your practice as a healthcare provider. So, as we get started here, I just want everyone to think about these three questions, and really reflect on these throughout this presentation, and see if there's any things that you learn from this that might kind of change how you view workplace violence and prevention as you move forward. So, in order to really understand workplace violence, I think it's really important that we know that what the definition of it really is. Um, and if you were anything like me, before I started diving into this world, I'm, I just really thought of workplace violence in regards to something that actually caused like a significant injury. But it's so much more than that. And it really affects us in so many ways. Um, but when we're not considering the verbal threats, harassment, those kind of things, then we're really missing out on what truly, or how truly workplace violence is affecting us. So this definition from OSHA here covers all workplaces, but the examples I've listed below are some of the most commonly seen within healthcare. So we do see physical assaults, but we also see a lot of attempts and threats of those assaults. We get a lot of verbal threats, a lot of harassment, whether it's in person or over the phone. And workplace violence can be patient mediated, visitor mediated, but it can also be in the form of the interprofessional bullying. And I think it's really important that we point that out, because we also don't necessarily always consider that workplace violence, but it very much is. And the days of nurses eating their young and providers talking down to nurses and support staff really should be long gone, and we should not be tolerating that type of behavior. So, where does this violence occur? And the truth is, everywhere. There is no healthcare setting that is immune to workplace violence. And it's often the settings that we least expect it, that we're the most unprepared to handle it. So, we know that emergency departments, psychiatric care areas tend to be really high risk. Um, and we often specialize our prevention to those areas. But what happens when a violent event occurs somewhere else? Are those care teams prepared? What is the response time to for our security teams to get to those areas? And do we even have a specialized team that can respond to those areas? Um, Living here in Montana, many of our hospitals and healthcare settings are in very rural areas. So much so that there may only be a handful of staff present at any given time. And law enforcement might have a very long response time. So we need to really think of how are we preparing those teams, not only to respond to a violent event, but to be able to recognize those signs early so that they can prioritize their safety, and utilize the resources that they do have available. And then some of the other really important areas to consider are home health settings, nursing homes, clinics. All of these areas are typically areas where there isn't security present or may not be readily available, and extra resources are just not commonly, commonly readily available. So how are we going to prepare nurses and healthcare providers to work in those areas and be safe? So these are some statistics in relation to the rates of occurrence of healthcare violence in the US. So the Department of Justice and Bureau of Labor Statistics had a report from 2021 to 2022 that showed that nearly 73% of all non-fatal workplace violence events are occurring in healthcare and social service settings. And this is second only to law enforcement, which is pretty alarming. And then the CDC also published a report in 2024 that showed that almost 50% of all non-fatal injuries, so these are workplace violence events that actually have an injury as an outcome, 50% of those are in healthcare, but healthcare providers only make up 10% of the entire national workforce here in the US. So overall, these statistics really show us just how disproportionately these types of events are occurring for us in healthcare compared to other work settings. And then one of the really alarming
Hey,
statistics
Kelsey.
that yeah.
Hey, one sec. We seem to be having a bit of issue with the slides, like when you advance going from one to the other. I don't know
Oh,
if you can minimize or close any other windows or something real quick just to get your bandwidth a little back on track. It just takes, it's like,
yeah.
sorry to interrupt
Mm,
you.
no,
I
that's
just don't want
okay.
anyone to miss all your stats and
Yes,
everything.
of course. Let me stop sharing here real quick. Okay, we'll see if that helps out there. And these, I think we'll be able to make all of these available too. So if I do lose track of anyone, we'll make sure that all these slides are available so that people can refer back. Um, okay, can everyone see this?
Yep, it looks good now.
Perfect. Um, so so back to one of the really alarming statistics was the rate of underreporting these events. And this is extremely important because those numbers that I just talked about previously, that 73% and that 50%, those are just based on what is actually being reported. But it's somewhere between like 50 to 90% of all of these events are unreported. So those statistics prior are probably actually a lot higher. And I'll talk a little bit more about reporting here in a minute. But it's just extremely important to remember. And it's kind of that, that old nursing saying is if it's not charted, it didn't happen. So if it's not reported, no one knows it's happening. Um, and the National Nurses United did a study that they published in 2024 of 1,000 nurses, and 81.6% of them reported experiencing at least one incidence of violence in the last year, and 50% said that they reported an increase in violent events. So we know, really no matter what source you look at, the evidence is clear that workplace violence in healthcare is a significant problem. And we really cannot continue to look away or tolerate these events without doing something about it. So this next slide here just really shows that this is not just an issue here in the US. We are seeing violence really globally throughout the world. I won't go into detail in all of these areas because they're not my specialty, but I think it's just really important to note that healthcare providers, especially nurses, are experiencing violence everywhere. So it really is not an isolated issue. And we really all need to kind of get together and figure out how to solve this. So now that we know that workplace violence is so prevalent, how is this affecting our workforce? And there's a few different ways it's really affecting our workforce. And, first and foremost, we think of injury. So we know that we have physical injury and we have emotional injury. And these injuries come with a financial cost. The Joint Commission posted or put up a report from a study that showed that on average, these injuries can cost hundreds of thousands of dollars for health systems. And I can, speak from personal experience. My injury was up there. It was very expensive. And it also costs, and that's just the direct cost of the injury and treatment alone. But we also need to think of the cost of, can this person return to work? Will they want to return to that health system at all? Or do they need to potentially rehab for a new position? Or are they going to leave healthcare altogether? So it's more than just that financial cost. It's really a workforce cost. But then we also need to look at burnout because we know that high frequency of exposure to workplace violence equals higher rates of burnout. And this is where those non-physical injuries really come into play and why it's really important to be reporting all of these events, even if they don't result in a physical injury. Because burnout and moral distress are often linked to that continuous exposure to that verbal abuse, threats, harassment, intimidation. And this ultimately leads to exhaustion, reduced sense of accomplishment, and depersonalization of our staff, which ultimately leads to nurses leaving the bedside. And if we're only focusing on those physical injury cases, we're really missing a huge opportunity to care for those who are experiencing this burnout, and the opportunity to remedy it and really retain our staff. Bullying and incivility also leads to those negative outcomes. So the culture of the unit also really matters. And then ultimately, all of these things directly affect patient care. If we are experiencing burnout and no longer really have that capacity to care deeply, then we start making more mistakes and we become checked out when it comes to engagement on our units. There's also a trend of increased mistakes happening due to fear of asking for help because of a poor unit culture and fear of being bullied on the unit. We also see that physical manifestations of that increased burnout and anxiety, they start to affect our sleep and increase anxiety, which ultimately inhibits our ability to critically think and care for our patients safely. So there's a lot of cost that is associated with workplace violence, and it's not just the physical injury that has the highest cost. So, I know that reporting has kind of been a common theme I've been talking about here, but it's really important to understand what is contributing to these factors of underreporting. And the most common were fear of retaliation and ultimately a sense of guilt that the person reporting had failed that patient in some way and that they really just needed to take responsibility themselves and not report the incident because they felt like it was their fault. Um, some of the other factors include patient diagnosis. So, for example, an elderly woman with a UTI who is confused and maybe physically combative might make you feel like you shouldn't report an injury that she caused because she didn't necessarily mean to. And we don't really want to get that patient in trouble. Um, but we also need to remember that reporting these events doesn't automatically mean that patient is getting in trouble, but it does allow for accurate tracking of what is happening. Um, Staff also reported that they felt like if they had cared for a patient better, that maybe these things wouldn't have happened. So they feel as though it was their fault and they didn't want to report the incident because of that. Um, and then there was also an overwhelming sentiment of that it's just part of the job and nothing's really ever going to be done anyways. And all of these things were common themes that I found in a few different qualitative studies. And these are sentiments that have really historically followed us throughout the years. So it's going to take a big culture shift to get away from this. And then lack of follow-up was also a really significant factor. When you take the time to put a report in and you never hear anything back, it really can make you feel like, as though no one really read the report or no one really cared. Because if they did read the report and they didn't, get back to you, then really what was the point of it? So when I looked at, what does encourage proper reporting, consistent follow-up was probably the number one thing. So every report made should have some kind of follow-up. And ultimately, if it's in-person follow-up, especially from leadership, that really showed the best engagement with teams. An emphasis on employee well-being and value of employees really decrease that sentiment of that nothing will ever change, and increase the likelihood of reporting from bedside staff. So if we don't have a culture of reporting, then we can really never truly know the extent of the problem. And this not only directly affects bedside staff, but also our leaders. So if staff aren't reporting, then leadership really has no way to track what's going on and really understand the extent of what's going on. But if the reporting system is cumbersome and reports are never followed up on, then staff will likely not engage and they won't be encouraged to report. So ultimately, when we're left without good reporting practices, then we're missing out on that ability to mitigate the effects of that workplace violence, and we're leading, to poor retention of our staff. So I am going to share some parts of my story now. And I think it's really important to note that I worked in multiple hospital health systems. I worked in home health, nursing homes, other healthcare areas. And the injury that I experienced easily could have happened in any one of those areas. It just happened to, occur in the area that I was working that day. Um, and ultimately, I have experienced so many near misses throughout my career that easily could have resulted in what happened this day. And the only difference is it just wasn't a near miss this day. It was actually truly the day that changed my life forever. And my story could easily be your story too. This is not meant to scare anyone, but really to empower you not to wait until your near miss becomes your life-changing day. And I really encourage you to engage in protecting yourself moving forward. So the day that I was injured was not out of the ordinary. I was a charge nurse in the ICU, and we had a mix of patients on our unit that were really no different than any other given day. But we had one particular patient who was experiencing a form of delirium, which is also very common in the ICU. And this led to that patient being very confused, unaware of where they were, unaware of what was going on, and quite scared due to all of that. The patient ultimately was acting out of what they felt to be self-defense, and we were the perceived threat. Um, so I won't share any, deeper details about the patient or their story. But what ended up ultimately happening was the patient hit me really hard. They uppercut me under my jaw with their forearm, and it dislocated my jaw temporarily. And my jaw popped back into place on its own. But from that single hit, I suffered severe damage to my jaw joints, and I required extensive reconstructive surgery a year later. And ultimately, I actually need total joint replacement of both of my jaw joints because of the damage that was done. So all it took was, one instance, one day, to leave me permanently injured for the rest of my life. I am unable to chew normally, and I probably never will be able to again. And this injury has really affected almost every part of my daily life, and has completely changed the trajectory of my career. So I am now a clinical nurse educator, and I absolutely love my job. But once upon a time before this injury happened, I was a flight nurse. And unfortunately, I will likely never be able to pursue that career path again due to this injury. I also had to give up many of my favorite recreational activities due to the fragility of my jaw. And this injury ultimately actually affected my wedding too. I had to have braces on during my wedding. And I'm not, as really concerned about how they looked, but every time I look back at a wedding photo, I see those braces and they remind me of the pain, and everything that I was going through at that time. And it's really unfortunate that, I had to experience something on the job that then affected all of these parts of my life. But ultimately, this is also where I still really cherish being a nurse, because it has given me the opportunity to pivot in my career. I've had to take some very hard, sharp turns that I wasn't expecting. But I am so grateful that I am a nurse because it has just opened up so many doors for me to really pivot and still have a healthy career. Um, One of the things that has been a really big battle for me, though, is that moral distress of being in a profession where I've dedicated myself to caring for others, and feeling at times as though I really lacked feeling cared for myself when I really needed it the most. So ultimately, that's why I'm here today, and why I've taken on this advocacy journey. Because as we know as nurses, we learn right out of the gate that our job is to advocate for our patients. And I'm here and dedicating a lot of my free time to advocating for nurses and the safety of healthcare professionals, and hopefully teaching you all here how to do the same. So this leads into really why advocacy and engagement is so important. As we now know, that violence is a significant problem, and you've heard my story and how this incident can, how all it takes is one incident to totally change your life. So this is where we now need to look at how do we change these outcomes? How do we change these statistics? And how do we prevent these severe events from happening? And ultimately, it all starts with knowledge and advocacy. So, whether you're an experienced nurse leader, a new to practice nurse, or even a nursing student, prevention belongs to all of us. And that might have to start with advocating for and engaging with starting new programs and learning more about how you can incorporate these prevention strategies into your own practice. And then I also like to briefly touch on the concept of the zero tolerance policy. And in theory, these are great, and I think a lot of healthcare institutions have them, but they only work if everyone is truly abiding by them. And zero tolerance policies are being broken if we are experiencing violence and we're not reporting it, and if we're not following up on these incidents and taking them seriously. So if we continue to brush things off as part of the job, and not take them seriously, then we're not really truly applying that zero tolerance approach. So now I just want to talk about, what is out there that gives us some guidelines for prevention and response to these violent events. Unfortunately, there are no national mandates or anything that makes any of this mandatory for healthcare institutions, but OSHA gives us a really great framework for kind of where to start. And I think these guidelines are often familiar to certain healthcare leaders and those who are responsible for healthcare procedures and policies. But I think as nurses, and those of us, working in the front line, we should really all be familiar with them as well, so that we can not only engage in promoting safety, but also come to the table equipped with knowledge when we see a gap and we want to figure out how to close that gap. Um, I don't have enough time to go through everything in detail, but these guidelines are definitely worth perusing through. But I just want to touch on some of the things that really stood out to me amongst all of my research, and where the evidence really showed what is working. So one of the big things is environmental controls. So that really means like what is the working environment you're in? What is the built environment? And do you have a good understanding of how that environment functions? So are you doing a quick scan of the room when you walk in a patient room or a care area? Are you identifying what objects might be able to be used as a weapon against you? Do you know how to position yourself if a patient or a family becomes escalated so you do not get trapped within that room? One of the common things I think about with that is, where are our computers placed in the room? Are they in a corner away from the door? Is the patient in between us and the door, or is our computer next to the door? Um, when we're designing new healthcare spaces, are we incorporating evidence-based design into those built environments? And evidence-based design is really important not only for the efficiency of our units, but truly the safety of them as well. And then are our units truly secured and locked down where they need to be? Or are we getting a little lax and letting people in or providing badge access to those who do not need it? The next thing is our administrative controls. So when we look at administrative controls, I found that it was a really common theme that structured debriefing was not always applied to these incidents, which is a huge missed opportunity to not only ensure that reporting occurs, but also that we are making staff feel supported immediately and not leaving them behind. Um, Also, engagement from the right people on workplace violence committees, or making sure that we do have a workplace violence committee to be reviewing these events. If we're not including frontline staff, and that includes, our nurses, our techs, but also our security friends, if we're not including them in these workplace violence committee meetings, then we're really missing the perspective of those who are experiencing these events firsthand. And then by far the most important thing was comprehensive training. And this is really what has led to a reduction in injury, as well as just the feeling prepared if these events do occur. And these programs truly must be comprehensive. So they must include de-escalation techniques, as well as hands-on opportunities for how to keep yourself safe if an event does become physically violent. The hope is always that we can use de-escalation techniques to prevent something from becoming violent, but the reality is we can't always do that. And these programs need to also extend beyond just training our nurses. We need to include our security team members. We need to include everyone on that interdisciplinary team who might be facing a patient. Um, and it's really important to include everyone who's going to be responding to these violent events so that we all have that same baseline training. So we all understand what the expectations are of us in these roles. And as a critical care nurse educator, I always think about how we do a really good job of simulating code blue, simulating resuscitation events so that the first time we meet the code team isn't when we're actually in a critical event. We're practicing it beforehand. And I think that's really important and a really missed opportunity with our security team members, because we often operate in silos away from them. But that really leads to a huge disconnect of what are the expectations of each of our roles. And the other thing that's really important is being able to understand the terminology that we're using for our security friends to be able to understand that. Because there is a huge fear of, how do all of the members of the team, take care of this patient in this critical heightened event. But if our security team doesn't understand the terminology we're using, if they don't understand what's going on in that room, they're going to be really afraid of harming that patient. So we need to be able to be on a solid baseline with them so that we're all speaking the same language and that we can all safely care for that patient if we do end up needing to put hands on them. And understanding what different members of that response team may or may not be able to do. We know in critical events that communication and clear expectations are really what make or break the outcomes of those critical situations. And again, we're really good at doing these big simulation and trainings for medical events. And I've also seen a lot of institutions do this for like active shooter drills and things like that. But it's also really important that we simulate the things that are kind of happening day to day as well, because those are really where a lot of these injuries are coming from. There's also a couple of other sets of guidelines that come from other countries. So Europe has the NICE guidelines, and these guidelines focus on really anticipation and mitigation. So they really focus on the fact that we know violence is going to happen, so let's plan for it, and really prioritizing that de-escalation training for all staff. The Registered Nurses Association of Ontario also has some good guidelines, and they really focus on communication skills training and then having those simulated opportunities to practice those skills as well. So this next slide here, and I'm hoping my slides are keeping up, but this next slide here are questions that I think are really important for not only bedside staff, but leaders to also really engage with. So I encourage you to ask this of your current workplace. And if you do not know the answers to these questions, then bring these forth to your leaders. So when you're starting your advocacy journey, you can really figure out what your institution has in place already. And if you're going to be starting a new job, these are really great questions to ask kind of out the gate so that you can know what's in place already. But I also don't want you to just come with these questions. I want you to also be prepared to help close the gaps that you might identify when you're asking these questions and be ready to be part of the solution. Because we really can't truly engage in changing that culture of safety if we don't get everyone involved. And this is a huge culture shift. So it really has to start not only with our leaders and our healthcare organizations, but with us working at the bedside too. So this might mean joining your workplace violence committee or even spearheading one if you don't have one. Coming to the table with evidence directly correlating to your specialty and providing resources that are already available to the public. And I'll touch on some of that here in the next slide. There's also a lot of different security consulting firms as well as de-escalation training programs. And I won't speak to any of those specifically, but I will encourage that you do your research and not just settle with the first one that you find. Make sure that you invest in something that truly fits your needs for where you are working and really specializes in healthcare. Because different forms of de-escalation and hands-on physical training are going to be better for those in the emergency department as compared to someone who's working in a pediatric unit. So it's very important that we just have the right training for the right people. And one other thing that I forgot to mention earlier is de-escalation. One of the things that I learned going through a few different de-escalation courses was it's, de-escalation. So, being able to bring a situation down is extremely important. But another huge component of that is actually not escalating the situation further. So, learning how we can check our own response to a situation so that we are not, escalating that further. And that also comes with really recognizing where we're at in our burnout journey, where we're at in our moral distress, and being able to have that good check-in with ourselves. So this next slide here, I've linked out a bunch of different resources, and then I also have them linked out. I put all the URLs in a different slide, so in case you're not able to click on these. But the CDC has a free online de-escalation course for nurses. So if where you're working doesn't offer a course, this is a great place to start. And then all of these other areas have different trainings and evidence for the specific, like the Emergency Nurses Association, American Association of Critical Care Nurses, Occupational Health Nurses Association. All of these different areas have evidence that is kind of directly related to that specific care area and some education relating to those, as well as position statements on how they are supporting violence prevention in those specific areas. I think another really important thing too is when you are bringing on a de-escalation training is thinking about the cadence at which you are doing it. because, I always think back to doing basic life support or advanced cardiac life support. We have to take the training and then we have to redo it every couple of years because we know that these critical events aren't happening every single day, most likely. So we're not going to be experts in that. And we really need to be keeping up with the evidence as well. And I think de-escalation and that hands-on training for safety and violence prevention should be thought of in the same way. We can't take one course and immediately be an expert in it. Um, and I've seen a few different things in different organizations and nursing schools. Some nursing schools have actually started incorporating de-escalation in their curriculum, and I think that's a great place to start. But it's also not enough. We need to be continuing it throughout the career phase. And then also some hospital organizations have actually started making it part of their initial orientation. So just like you have to have a BLS card before you hit the floor, you need to have taken a de-escalation training. So they build it into their orientation so that everyone across the organization all has the same training, which I think is super important. All right. So we really know that, workplace violence isn't fun to talk about, but we do know with all of these statistics and information that's coming that it's really not an if, but a when that we're going to experience some kind of exposure to it. So it's really important that we acknowledge this and we know this so that we can equip ourselves with the right training, the right education to be able to keep ourselves safe in the environments that we're working in. And that is all I have. So I will open things up to questions that you all might have.
Hi, Kelsey. All right, just a few compliments first, and then I have questions for you. So, first, someone would like to thank you for sharing your story and advocating for educating the profession. So, thank you for that. And then also, they like the emphasis on de-escalation training because we need to all know what to do and to be on the same page to keep everyone safe. So thank you for sharing those important things. And a question we have you found by educating other nurses in workplace violence has helped in your healing?
Oh, I think it's been extremely helpful. Uh, I think for me, and I think, for a lot of nurses, we're really good at taking care of others, but we don't always learn how to take care of ourselves. And this was something that I found not only helped me take care of others, by engaging in this prevention, but it really healed a lot of parts of me. And I really learned throughout my journey of sharing my story. I've had a lot of other people share their stories with me as well. And I think it just goes to show that, there's a lot of people that, for whatever reason, can't share their story. And I've really made it an important part of my journey to, I do have the privilege of being able to share my story and to get out there and speak on a few different platforms. So it's been very healing and very much knowing that I'm out there, kind of speaking for the profession as a whole and hopefully making some good change along the way.
Great, thank you for that. All right. Also, we'd like to know, are there particular de-escalation training programs that you would recommend?
Oh goodness. I I guess I don't really want to promote anything specifically because there are so many different types of programs out there. But what I will say is the components that I've found that were really, really important and I think the most helpful for working in kind of the hospital setting was a program that I've taken that has very heavy focus on, that de-escalation part, but it also really heavily focused on how we are interpreting these situations. So how we're recognizing these situations, how we can start that de-escalation well before the event really even gets escalated. So I think having a program that really has a strong kind of didactic portion and really kind of going back to understanding the psychosocial part of nursing. I think a lot of us haven't had a lot of that since nursing school, unless you are working in a specific psychiatric care area. So I think having a program that has that as a huge component, but then also having the hands-on, being able to learn self-defense that is specific for patients, because our ultimate goal is to safely take care of patients. We do not want to cause harm to our patients. And a lot of times that's the barrier in us being able to maybe safely restrain a patient if we need to. We kind of let things happen to us out of fear of not wanting to hurt our patients. So if we can learn how to safely do certain techniques where we can, safely restrain a patient if we ultimately need to, or if we're in an event where a patient or a family member, visitor, someone is potentially holding us hostage, being able to learn those hands-on techniques. So having, I think the best program I've taken is one that had all of those components built in. There's some other programs that are very heavily focused on that self-defense. And those might be really appropriate for people who are working in environments where you are exposed to a lot of physical danger. But if you're missing out on that de-escalation component and that psychosocial component, I think that's a really big missed opportunity. So that's kind of why I hate to promote any specific things, but when you are, looking into these programs, being able to ask the right questions for the unit that you are working in is so important.
Thank you for that, Kelsey. What services do you recommend for individuals who have been victims of workplace violence? Anything in
Yeah,
particular?
this is so important. So I think that, there's a few different things that I sought out after my injury. And I've been a lifelong person who has I've been in therapy throughout my life for all sorts of different things, but I think that was the number one most important thing was getting therapy afterwards. But having a therapist who understood the specific type of PTSD and what it was like to be a healthcare provider, that's what really worked well for me. And then also finding some debriefing and support groups. I actually ended up finding that online through a few different social media platforms, actually. There's some really great nursing debriefing groups and support groups that were really helpful to just connect with other people who had kind of experienced it. And when I experienced my assault event, it was also unique because it was at the height of the pandemic. So I was kind of dealing with multiple things. And so I found that really, really important to just be able to feel that, camaraderie of people who truly understood. Because if you're not working in healthcare, you really can't understand what it's like to feel kind of that betrayal of being injured on the job or being treated really poorly when you're trying to help care for others. So I think, finding a community that you can talk to about it. I did not end up using my organization's I think they call it an EAP plan. So that's where a lot of organizations do actually have programs where you can get free therapy for kind of a no questions asked. Doesn't really matter what it is. But I think those are really great resources to utilize as well. I had just already been established with my therapist at the time. So that was a really convenient way for me to just kind of keep going with who I was established with.
Great resources. Thank you for sharing. Um, all right. So how has the thought that confused, agitated, or ill patients should not be held responsible for acts of violence impacted your advocacy and education efforts?
So I think it's, this has been a big part of my story because I went through a lot of very conflicting things in my specific incident with the particular patient that assaulted me. And I think ultimately it's a very personal thing, because, each individual knows the situation that they were in, whoever it was that caused their harm. And for me, ultimately, I, kind of had to make peace with the fact that, the patient truly did not have any clue what was going on. They did not know who I was. They did not know where they were. And outside of this specific, event and environment, this was not the kind of person that they were. And this is where I think it's truly important to, um, that we look at workplace violence as this, kind of universal precautions. We need to expect, everyone is human and everyone is kind of one bad day from having a really bad day. And that's not to say that we need to just accept these kind of violent things, but we need to be well prepared for them because we know that, there are so many different reasons why a patient might be confused. I did a podcast with a delirium specialist, and she talked a lot about a family member who had. I can't remember the specific situation, but they ended up hospitalized and they were very young, very strong, and they, were very confused. And it really, they had no control over what they were doing. So it's very hard to feel like, we can punish someone when they're not in their right mind, but that does not mean we should not be prepared for these situations. And that's where we kind of, and for me, where I've had to kind of shift that culture of, we can't just punish everybody, and change what's happening, because people who are truly not in their right mind, who are not making good judgment, who can't think clearly, punishing them isn't going to change anything, and it's not going to support them either.
All right, next question. Sometimes people do not report because they feel like nothing will be done. What would your response to that be, I guess, from your standpoint?
Yeah, so I think it kind of depends on, who you are in that paradigm. So I think, as a nurse leader, you need to look at, this evidence that's out there and, really figure out how can I make sure that every report that comes through is going to be addressed in some way. And letting your team know, if there is going to be a culture shift of, hey, I know historically we haven't always followed up, but we're going to improve on that and letting people know and really encourage that reporting. And if you're bedside staff and you're the one who's experiencing that, sentiment of feeling like nothing is being done, follow up on the reports, but also bring forth the evidence, bring forth the, hey, when we hear nothing back, it really, doesn't make us feel good. And there's actually a lot of evidence that states that that is highly attributed to us just not reporting in general. So I think, it has to come from both sides. But I think ultimately making sure that, we understand that that's probably a huge barrier and that we need to address it and we need to really shift that culture um, from both leadership and bedside staff.
All right. Do you know, Kelsey, if there are tools or scales built into EMRs to alert staff to potential incidences of violence for certain patients?
There are. I know there is I think it's called the Brasset tool, and I might be saying that incorrectly. But depending on where you're working, there's different violence scales, and a lot of EMRs do have those built in. So I think that's something to, look to your organization, whatever EMR you're using. I know that I spoke with someone at another conference that works for a really big organization or a really big EMR system. And they said that they actually have a lot of really underutilized tools. So that can be a great thing to connect with your IT administrators who are working, who kind of support your EMR and see what tools might be out there if you've never seen them before, because they're definitely out there. And there's a lot of, I think, new tools getting built that are using some components of AI and different things like that to kind of look historically, but also to make sure that we're not prematurely flagging patients based on one incident and kind of flagging them for the rest of their lives in the system. So it's there's some good systems that are definitely coming forward for sure.
All right. So I know this can obviously vary depending on your employer, but um, what in, um, what requirements do employers have to help you if you've been injured by a patient? And in your instance, did workers' comp or anything help you cover the cost of your therapy and things related to the event?
Yeah, so that very much is employer dependent. So that is why some of those questions out the gate, I always encourage everyone to really engage with their employer, especially if you're starting a new job, to ask what are those expectations and um, what is available to me. I can't speak really broadly, but I can speak to my personal experience. I was covered under workman's comp. And there were certain things covered and certain things that weren't covered because there have to be everything has to be directly, relatable to that specific event. So I think that's also something that, the workman's comp system, it is an insurance system, but it's also mandated by state law. So that's where a lot of limitations come, is not necessarily the insurance company, but your state laws that mandate what is covered. Time off of work, how much is covered, and how you have to kind of jump through the different stages of getting treatment. Ultimately, I had to have my reconstructive surgery in a different state. I had to travel all the way across the country, and I've had to travel multiple times a year for the last 4 years. And that definitely became very stressful and very difficult to navigate. But I was also very lucky because I had a really great team in terms of the workman's comp system that were very supportive for me. But I know not everybody um, gets that. And for me, once I started working with the workman's comp system, it kind of became separate from the hospital, just so that um, for privacy things like that. So it's it's not easy. And I do think if you find yourself in an event where you do have a significant injury or you do need significant help, um, if it is in your wheelhouse to pursue just getting some kind of legal support to help you navigate all those ins and outs, I think that can be very, very important because it is very confusing, even as someone who works in healthcare, learning the ins and outs of that system were very hard.
All right, another question. So a compliment, thank you for your story and the resources for nurses to equip ourselves with tools to respond to violence in the workplace. What are your thoughts on how we as a profession can advocate for violence prevention that does not place responsibility squarely on nurses?
So I think that really lies on how we're engaging with leadership. So I think this is where, and I had this question come up somewhere else where they had been, offered a de-escalation training. They really loved it, and then it was never really offered again. And when they asked about it, it was, said that they couldn't do it again. So I think this is where, how we come prepared to the table to engage with our leadership and really show the evidence, show why this is important. Um, because again, it shouldn't all be on us. But sometimes again, if these problems aren't very obvious that they are causing true issues, so that's where reporting is a big thing. But bringing forth the evidence that's already out there, so we can show, hey, this really actually is a big issue. And probably a lot of components of this that you might not even notice because just because we might not have a lot of physical injury events, we have a lot of other events that are happening that are probably, closely related to our burnout and loss of staff and all of these things. And figuring out how you can engage with your leaders to not only show that, hey, we want all these education opportunities, we want these things, but we need you to help provide them for us. But if you do provide them, we will come. Because I think that's another, big issue is, a lot of times, we kind of turn into a squeaky wheel and then things happen and then we disengage after that. So we have to figure out where that balance is of engaging and being part of the solution, and, making sure that we're, getting our leaders on board so that we can all kind of be part of it. But it shouldn't just be on us at the bedside for sure.
All right. Apologies, we are running out of time to get to everyone's questions. So I apologize that we're not going to be able to get to everything. But have you ever heard of, this will be our last question, and then I'll close it out. But have you ever heard of any type of simulation or things to help mitigate workplace violence as far as preparing or practicing with that type of tool?
So I haven't heard of like any formal programs where you could go, like purchase a simulation package or something like that. But I do know of institutions that have partnered with their psych nursing staff because they really are the experts in a lot of this de-escalation. That's a big part of what they do. So they've kind of partnered with their psych nursing teams to bring forth like some scenarios. Sometimes those psych nurses are actually, they're the actors themselves so that you can work with, a real person because they've seen a lot of things. And so they kind of know how, how to practice these events. And then I have seen practice with kind of some interdisciplinary practice with security teams on being able to practice some of that physical stuff. It does obviously require some specialty training, to keep yourself safe. We're obviously not going to be probably learning any karate moves on the job or anything like that. But I have seen that incorporated in some of the de-escalation trainings as actual practice with partners on doing different techniques on how to, get your hand out of a wrist hold, or if someone is holding you across your neck, different things like that. But I don't know of any formal programs out there, although there might be.
All right, Kelsey. Well, thank you so much for sharing your story with us today. We are grateful that you took the time to share your experience and talk about this important issue. And we look forward to hearing more from you in the future, maybe in March 2026. No, no pressure, but we hope you have enjoyed this webinar. If you have a story to share or are doing work on this subject matter, just like Kelsey, or even a different subject matter related to creating a healthy work environment, please consider submitting an abstract by October 17th for our Creating Healthy Work Environment 2026 event in March 2026. Call for abstracts is currently open. All right, so we have an evaluation that we are going to post. We will also email this, so if you're not able to click the link in the chat, you will receive an email so you can complete your evaluation for your NCPD contact hours. To complete the evaluation and obtain your NCPD certificate, click the link that we've posted, and you'll get that email as well. We will also email the link to the slides so that anyone that you want to go back and reference that might have looked a little wonky, you can go back and take a look at those when you have a chance, and we'll have the recording as well. All right, so thank you all for joining us, and we hope you have a wonderful day. And thanks again to Kelsey for being brave and sharing her story. Thank you.
Thank you, everyone.